Good evening, all. You are all welcome to this session of our discussion of MCQs. And these MCQs will basically cover perioperative care of a surgical patient. And the MCQs are all drawn from BAJA or BEDU, Principle of Practice of Surgery, including pathology in the tropics. So if you have any challenge with any question, you can refer to that textbook. You'll have a detailed explanation on the question because the way things are going, it is expected we know conditions that are common, especially in our environment, and how to answer questions around them. So today is not a lecture, as you can see. It's a group discussion where we allow all of you, the participants, to answer questions. So you will be asked and you answer the questions. The format is going to be true or false. Even though this is not the typical way your exams feature, most exams now are choosing the single best option. But however, this is just for teaching purpose or for discussion purpose. That's why we use this format. So without wasting much of your time, we'll start the question. So it is expected you unmute your mics since it's going to be a discussion session. If you don't have a noisy background, you can unmute your mic. If you have a noisy background, you unmute your mic when you are asked questions or when you want to make a comment. Okay? So we are going to start with the first question. But before I go ahead, when we say perioperative care of a surgical patient, you should know it is basically talking about the care that is given to a patient before a surgical procedure. That is the pre-operative care or the par-operative care or the intraoperative care. Then the post-operative care, which is usually given after a procedure until recovery. So it's a procedure, it's measures taken from SOPD, the clinic, to discharge of a patient. Okay, so some of the questions will feature preoperative evaluation of a patient. Some are during anesthesia and others are in the post-operative period. Now let's start with the first question. Let me get a focal person that I'll always, if everybody is quiet, let me see who will be my focal person that I'll always ask. so that you will be in trouble. Dr. Sakina, I can see you. Dr. Sakina, are you with me?
Yes, I'm with you.
Okay, so if you run into trouble, where is Ali? Where's Dr. Ali? You are trying to log out. You are not going anywhere. I saw you logging in. Dr. Kashim Ali.
Sir.
Okay. So you are not going anywhere. If you run into trouble, you are the one that will bail us out.
Okay, sir. Yeah.
Around. Okay. Now, if I read the question, please, if you want to attempt the answer, you can. Any among, because it's a discussion. In fact, you can open your textbook. This is a group discussion. We are all learning from the questions. So the first question says investigations that must be done as part of the pre-operative assessment of fitness before an emergency appendectomy in a 30-year-old man include A, chest X-ray, B, urinalysis for albumin, casts for sugar, okay? Stool R&E, that is microscopy. Dr. Kashi, are you answering the question? I can see you have a noisy background. If you are not answering a question, just mute your mic, except you want to answer a question or make a comment. Okay. Sickling and hemoglobin. E, white cell count. So I need a volunteer to answer. Dr. Sakina, where are you?
Okay, so I'll go for option E, white cell count.
Investigation that must be done. Look at the question. That must be done.
Sir, I think the answer is B, urinalysis for albumin, casts, and sugar.
Now, I'm underlying some important points. Now, Dr. Sakina, why did you say white blood cell count? Let's hear your reason.
Okay, so the white blood cell count will give us an idea the PCV of the patient. It will also give us an idea the platelets, which will be important for us to know during the surgery so the patient doesn't bleed. And it will also give us an idea of the white blood cell count. So that's why I went for option E.
You are confusing it with full blood count.
Oh, okay. White cell count. Oh, I didn't see it. I'll go for option B.
See how quick you are to choose. Your mind is already going for a full blood count where you assess white blood cell count, which is a component, hemoglobin or PC, platelets, and other parameters. So you see, obviously this is wrong. Dr. Hashim, why do you choose? What is your option? Where is Dr. Kashim? I thought you chose an answer.
No, sir, I didn't participate.
Who answered?
But I will go. I'll still go for E.
Okay, who answered some? Oh, you are still going for E after the explanation I gave you.
Yes, sir. I'll be looking for leukocytosis.
I thought you said B, sir. B for boy.
Okay, you said B. Who chose B?
It was me.
Who? Who is that?
Man.
Dr.
Lukman.
Okay, Dr.
Okay.
Why did you choose B?
Sir, because it says for operative fitness.
So you need to know if the kidneys are and the albumin is okay before you put them under the anesthesia.
Yes.
I'll choose E.
I'm still going for it. It seems.
E. Just
I thought you
E.
said boys, sir. B for boys.
Is it that my mic is muted or what? I just gave explanation why it's not E.
But it could be E. No, it can't be E. E is cat.
You need to rule out infection, sir.
Is fitness for emergency surgery. So it's about the surgery, not about the infection. You have to know
Okay.
if they can go a surgery or not.
Nice.
So you need to confirm if the kidney is still working, it's okay or not. Because if you give anesthesia, it will worsen it.
Okay.
So our answer here, A, true or false. I said we'll answer true or false because we want to answer more options. Is A true or false? Musts. Let me underline this. Musts to fitness before emergency appendectomy. And look at the age of the patient. Is this true or false?
It's false.
A is false. A is false.
False.
False. Why is it false? Because of the age. It is 40 years and above.
Oh.
Yeah, you are looking for cardiac problems. Now for fitness, because an emergency procedure like appendectomy, okay, the basic or it is called the minimal investigations you do. You know, investigations in emergencies are minimal you do, the basic ones when indicated, and those you must do. Now, in some certain instances, you don't have to go doing extensive investigations just for an emergency acute appendicitis. You just want to do the minimal that will determine fitness. And the guy that said B is right. Urinalysis is a bedside minimal investigation that will show maybe fitness for the kidneys, okay? It will assess for fitness of the kidneys. Then stool, MCS. Let's say stool MCS. True or false? So this is true. Sorry, B is true. Are we together?
Yes, sir. We're together.
So B
Yes,
is.
sir.
What of C?
False.
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 Excellent. Sickling and hemoglobin.
False.
Why is it false? You don't.
No, sir, it's not
True,
false.
sir.
It's true.
True, sir.
Sickling and hemoglobin is true.
Why is it true?
Hemoglobin will give us an idea of the PCV, and then sickling to know if the patient is a sickle cell patient.
Now, I'll refer you to that chapter in Bedu, the way he classified the investigations, okay, before in procedures. There are some basic minimal you do, which B and E are part of. Is it clear?
Yes, sir.
First, we explain why E is false. Okay, let's move to the next question. A 40-year-old woman is to have partial gastrectomy for simple gastric ulcer. Now, I want you to pay attention to two information in this question. The operation is involving the stomach. So it's upper abdominal surgery, okay? And all upper abdominal surgeries might affect the breathing of that patient. In the post-operative period, they might develop atelectasis because of pain. They might decide they might not want to breathe. So you give general analgesia, infiltrate after surgery, early chest physiotherapy to prevent atelectasis. Now, the second part of this question is indicating that it's a benign condition. Hope is clear. It is a benign condition, not a malignant one. Now, in the pre-anesthetic assessments, the point to be noted. Now, I just raise this point so that you know how to analyze questions. Because there are some key points. Maybe subsequent questions that will follow these are important. Now, in the pre-anesthetic assessments, the points to be noted in the history include A, previous operation and anesthetic experience, drug therapy, previous dysentery and urinary difficulty, social habits regarding alcohol and tobacco, concurrent disease. Yes, who wants to attempt?
Okay, so I'll go for option D.
It's true or false?
Social. Okay, true or false?
So A is what?
True.
A is true.
A is true.
Why
A
is,
is true.
why is A true?
Risk factor.
I don't understand risk factor. Previous operation and anesthetic experience. Why is it true?
To note when the operation happened, the anesthetic was given, and if it might cause for like further complications. Any complications in the previous surgery as well.
Yes, previous operations is important. You know, when a patient have previous operation, especially abdominal operation, they are at risk of developing what? When you are going back for another abdominal operation. Yes, they are at risk at developing what, Dr. Sekina?
Sorry, sir, no idea.
When you operate on a patient, abdominal surgery, you are going for another abdominal surgery. What happens? What is the complication they are prone to?
Adhesions.
Excellent. When they have adhesions, what happens as you are trying to open the abdomen?
They can have iatrogenic bowel injury.
Have bowel injury. The adhesions is between the intestine and the previous scar. So when you are making an incision, you make what is called a virgin incision from a site where there is no what? Scar. I hope that is clear so that you don't enter a bowel. Let me demonstrate that. If this is the abdomen and there's a previous scar here, you know, from the interior, from the abdominal cavity, from the peritoneal cavity, the intestines have adhered to this from inner. So if you want to make incision, you start from a virgin area so that you can mobilize this intestine away from that. So if a patient have previous abdominal operation, they are at risk of developing complications like enterotomies. You injure the bowel when you are trying to go in. Now, if they have previous anesthetic complications, that is important, okay? You know what drugs were used, what were the complications that were used, is the patient reacting to any of the anesthetic drug? Is there any previous exposure to anesthesia? You want to know that. And the events surrounding that anesthesia. So A is true. Now B, drug therapy. Yes, true or false?
It's true.
True. Yes. Previous dysentery and urinary difficulty.
False.
False, of course, it's false. Why is it false?
It's an acute illness. It doesn't have anything to do with the current surgery.
Excellent. Social habits regarding alcohol and tobacco, true or false?
It's true.
What is the effect of alcohol on surgery?
Alcohol prevents the neutrophils from clearing out infection,
It
and it
also
also
delays.
suppresses the bone marrow. It's toxic to the bone marrow.
Excellent. Alcohol is toxic to the bone marrow, so it depresses all the cell lining. It can cause anemia. Alcohol affects the liver function test. It affects the liver function. So you have a deranged liver function. The patient is on alcohol. You want to stop alcohol for at least a month so that all the liver enzymes normalize. Okay, it impairs wound healing. And so tobacco, what is the effect of tobacco? Yes.
It decreases the oxygenation of the blood in a patient, and then it also affects breathing too.
Yes.
And then it suppresses the ciliary action. That's the mucociliary action of the respiratory epithelium. As such, the patient may not be able to clear out mucus.
Yes.
Maybe
So
after the general anesthesia.
when the ciliary actions are suppressed and there's mucus accumulation, stasis, infection, they develop postoperative pneumonia. Tobacco can also cause vasoconstriction. Don't forget, just a stick of tobacco. One stick of tobacco can cause vasoconstriction for about 90 minutes. And this will interfere, it will impair your wound healing. Okay? There are several effects of tobacco, but the ones we are concerned with are those around the perioperative period. Okay? Now, concurrent disease, true or false?
True.
True.
Okay. The operation should be postponed. We are still talking about that woman going for upper abdominal operation, and is for benign condition. Okay. The operation should be postponed if she has cold. True or false?
True.
Why? Who said true?
Oh, okay. So I was the one that said true.
Why?
It can lead to pneumonia. The cold, it can. Okay, maybe if it's an upper respiratory tract infection, it can spread to the lower respiratory tract and cause pneumonia for the patient.
So if a patient have upper respiratory tract infection from viral infection with an hypersensitive airway, they are prone to developing what? Post-operative pneumonia, excessive secretions during anesthesia. They are more prone to infection, and of course, ventilation and all that. Mucus, because of edema around the airway from mucus secretion. Because if you try to intubate, you cause more and more stimulation of secretion, edema, and in the post-operative period, this mucus can even plug the airway, and patient will develop post-operative atelectasis of pneumonia. So you don't want to do any case you can postpone. This is a peptic ulcer disease, for God's sake, that you can give treatment. Except they come as an emergency, that is a different case. Okay. So A is true. B, the operation should be postponed if she has diabetes for which she has been receiving treatment. True or false?
False.
False, because it's control. It's not also. She has history of asthma. The operation should be postponed.
No, false.
All these are things that can be controlled. Is that not so?
Mm-hmm.
Okay. Clinical examination does not reveal any abnormality. The investigation that must be done include A, chest X-ray. Are we together?
Yes, false.
How old is she?
Oh.
Let's go back to her.
She's 40.
Oh, you don't want to do X-ray for her? Yes?
Yes, she needs X-ray because
She needs
she's
X-ray. We just talked about that
yeah, because
patients are more than 40 years, okay, that is going for a major operation. You do X-ray, you do ECG. Is that
yes.
why? Why is that so?
Wait, because of the age and they are more prone to something.
We don't know what something is. Yes? Above 40
I didn't know.
years. You want to evaluate, you want to do cardiac evaluation for a patient going for major surgery. You want to do cardiac evaluation for a patient more than 40 years. Why is that so? Yes? Who wants to answer?
The X-ray, okay, it will show us if the patient has an underlying hypertensive heart disease, and the ECG can also give us an idea if there was a recent MI, myocardial infarction or not, which will affect the outcome of the patient's surgery.
How will you see features of long-standing hypertension in that X-ray? How will you see long-standing
There will
hypertension?
be cardiomegaly. The heart will be enlarged.
If the heart is not large, how will you see a long-standing hypertension?
Unfolding of the aorta.
Unfolding of the aorta. Good. Yes. So you might see cardiomegaly, of course, but unfolding of the aorta is more representing. Yes. So this is true. B, clinical examination does not reveal any, look at, this is very important, does not reveal any abnormality. The investigation that must, let me underline, must be done. Yes. B, blood urea and electrolytes.
True.
Yes, go ahead, tell us why is it true.
Okay, blood urea and electrolytes is part of the minimum investigation that should be done before surgery, and it also give us an idea about the state of the patient's kidney function.
I don't agree it's part of the minimum. The minimal that gives kidney function is urinalysis. Now, I told you, you must go and review that parts that classify minimal investigations before anesthesia and surgery. They include hemoglobin, PCV cycling, then urinalysis, because you can just take PCV and take patients for a case that does not really require extensive evaluation. You can just do PCV and urinalysis. Example is acute appendicitis in a patient who does not have risk. Okay? You can check for when it's related to something you are thinking of, gastrointestinal something, you can do stool for amoeba worms. Okay? Now, if patient is hypertensive or patient that is above 40, the minimal that must be done, okay, are chest X-ray, ECG, and fasting blood sugar. Is that clear? If
Yes, sir.
patient is above 40, their own minimal now, you see that first patient we talked about is 30 years or less. It's acute appendicitis. Their minimal is just you check the PCV, you do urinalysis, cycling tests, or you may add stool MCS. But for patients that are above 40, their own minimal, you must do chest X-ray for obvious reasons. okay, because they are more above 40 are risk for having hypertensive heart diseases. And of course, what are the problems of taking a patient for surgery with an uncontrolled hypertension? What will happen? Yes? Who knows? This class is too quiet too. Remember, it's
The
not.
What's
patient
the
can
question? What's the
develop
question?
cardiac arrest.
It's group discussion, it's not lecture, please. Let's discuss, let's share ideas, let's understand pathophysiology. The question is, what is the problem of taking a patient for surgery with an uncontrolled hypertension? If a patient has uncontrolled hypertension, you rushed into surgery, what will happen?
The patient will be at risk of cardiac arrest while on table.
Why? You see, patients with an uncontrolled hypertension, they might not just go into cardiac arrest straight ahead. It starts with what? Arrhythmias, okay? Is that not so?
Yes, sir.
Now, there are some drugs that may interfere with the blood pressure. These drugs might even worsen the blood pressure, like ketamine. It rises the blood. Patient can develop stroke. Do you know that? Patient with uncontrolled hypertension, you take that patient to the theater, you give an anesthetic drug that rises BP, patient will just develop a cerebrovascular accident. Some drugs cause arrhythmias. Now, you should know a patient that is on hypertensive drug and you take the patient to theater, okay? And especially that drug is a long-acting antihypertensive. You just take that patient to theater and you give drugs. That drug may still be interfering with your drugs and patient will remain hypotensive. Okay? So there are several. Now, a patient might be, what if a patient have a long standing high blood pressure? You just take the patient to the theater and crash the BP suddenly. What is the problem with that? Where is Hashim? Hashim,
So,
the patient, did you hear the question?
yes, like that if a patient with long-standing uncontrolled hypertension is taken to the theater and then his BP is crashed,
Suddenly. What is it?
suddenly maybe he may develop ischemic cerebrovascular accident because of hypoperfusion.
Yes, because yes, they will develop ischemic complications because you see what you need to understand, this body has adapted to a certain elevated blood pressure for a very long time. Okay? And you just take that patient to the theater and suddenly crash the BP. Yes, they may develop ischemic heart disease, ischemic complications, because they have been adapted for a very high blood pressure for a very long time. Don't say, oh, don't worry, when we go to the theater, the anesthetic drugs will crash the BP. You are posing that patient to a very high risk. So you have to control the blood pressure gradually, except it's an emergency. Okay? Yes, let's go back to our question. Oh, we just answered one. How many did I say minimum for those that are more than 40 years?
3.
ECG, is that not so?
Yes.
Yes. ECG.
And what? Fasting blood
And
sugar.
chest X-ray, fasting and chest X-ray.
Yes, so that diabetes. So any patient that is more than 40 years, these are the minimum you should do, please. Okay, there are some other investigations that are indicated in any patient going for surgery, not because they are minimal or because if you are doing full preoperative evaluation, there are baseline investigations that are indicated. You must do full blood count for that patient. You must do U and E for that patient. Is that not so? You must group
Yes.
your SMART. All these are baseline things you must do. Okay? Yes. You must do full evaluation of patient because now, but we are being particular about this question of a 40-year-old that is going for a major surgery now. The clinical examination does not reveal any abnormality. The investigation that must be done in this 40-year-old, okay, what will be our answer? The minimal that must be done. That is what this question is asking you. The minimal for a 40-year-old that must be done are these three. Is it confusing?
No, sir.
Okay. Obesity. Obesity is becoming a challenge in our environment because of westernization and adoption of Western diets. And now all the complications of obesity, we are seeing them, not only surgical complications, not only malignancies, even during preparation of patient for surgery. Obesity predisposes to A, airway obstruction, true or false?
True.
Why? Because they have short neck. Have you ever seen an obese patient with long neck?
No, sir.
Okay, so A is true. B, respiratory infection.
True.
Why? Yes, why do they have respiratory infection? Because they are fat.
With the fat tissues predispose them to infections.
Obesity has risk for respiratory infection. Why is that so? Ah, who said true? Yes, who said true? Why this class is not becoming a discussion class again?
Okay, so I think they are at risk of respiratory infection because they have decreased inspired air, and that can lead to stasis in the respiratory tract.
Decrease inspired air. What do you mean by decrease inspired air?
Because of their short neck, so they may not be
Short
able
neck
to.
intubation. Our neck has not, breathing and neck are different now. When you breathe, is it not the chest? Breathing is taking in air, okay, and breathing out air. So what happens to, let's say, respiratory excursion in the obese individual? Is there?
So they have immunocompression a little bit.
Yes, that is, of course, they have immunosuppression because of reduced immunity. Yes, what again?
They will probably have sleep apnea and that
Respiratory
may
apnea. Another reason,
yes.
yes, respiratory sleep apnea. Yes. Now you are talking. Who else? Who said that? What again? After respiratory sleep apnea. Okay. Of course, even their respiratory excursion, their vital capacity, all these things are reduced in obese individual. Okay, so obesity is a serious problem. Okay, so wound infection, true or false? You see, somebody is whispering the answer.
True,
It's
sir.
true. True.
True, sir. True, sir.
Why is it true?
I think the fat tissues, because they hinder wound healing.
Yes, because of the fat tissues have decreased perfusion. Okay,
Yes, sir.
they have
Yes,
decreased perfusion, so there will be decreased oxygen delivery to that wound because it is impaired by
yes, sir.
fats. Okay, they are poorly perfused, so oxygen will not get to the wound. Yes, and also they have immunosuppression. They are prone to diabetes mellitus, type 2 diabetes mellitus, which further worsens immunosuppression. Okay, but basically you should know that those fat layer is a layer that will impair adequate perfusion and impair wound healing. Okay, urinary tract infection, true or false?
False.
False. Why is it false?
Obesity doesn't predispose to any urinary tract abnormality. So I don't think it will predispose them to urinary tract infection.
Yes, it doesn't cause any form of obstructive neuropathy. So it's not a cause of urinary tract infection. DVT.
True.
True, sir.
Why?
True, sir.
True.
Why is it?
Immobility.
Yes, I can hear that. Your network is
Decreased mobility.
okay because of stasis. Okay, right. A diabetic for operation must, if possible, be placed in the middle of operation list. True.
It's false.
False.
This is because you give diabetic patients priority because they will be fasting, so you don't want to keep them fasting for a long time because it can lead to diabetic ketoacidosis.
They can go into hypoglycemia. Okay, they can go into hypoglycemia, and hypoglycemia, in fact, it's better to leave for a patient with hyperglycemia than hypoglycemia because hypoglycemia causes irreversible brain injury. Okay, it's better to err on the side of hyperglycemia than hypoglycemia. So, patients you are taking for surgery, diabetic patients should be first on the list, okay, because they are fasting and prolonged fasting. You can predispose them to hypoglycemia and they'll go into other form of diabetic complications. So this is false. They should be first, not middle, not last. A diabetic patient for operation must have his blood sugar done before and after operation. True or false? Am I alone?
True.
True, sir.
True.
True, sir.
Okay, yes, true. C, not be giving insulin before surgery.
It's false. Diabetic patients are mostly stabilized on doses of soluble insulin before surgery in order to have a normal glucose level. So C is false.
Do you all agree with her? A diabetic for operation must
Okay,
not,
those I didn't mean most, not all of them. Some
because
are being given insulin.
this must not be given insulin before operation. Now, you should know all major operations, okay? All emergencies, all the oral drugs are withheld and converted to insulin. Is it clear?
Yes, sir.
So if you said must not be given insulin before operation, you see there's a problem there. Okay? There are some that are on diet going for minor operation, like you want to just exercise lipoma, a day case. You don't need to give them insulin. You don't even need to give them drug. Okay? They are already on that. There are some that are on oral hypoglycemic drug. If you are going for an intermediate surgery that does not require insulin therapy, what you just do, you beforehand during their preparation, you stop them from taking long-acting oral hypoglycemic drugs like biguanide group, and you convert them to short-acting ones like sulfonylureas, because oral hypoglycemic drug is something you cannot control until the body metabolizes that. But insulin is something you can control and monitor. You reduce the dose, increase the dose, or give glucose. And that is something that is flexible. You can. Now, so C, we said C is false. Have his urine tested 4 hours after operation. True or false? Just C is an
First,
Do we test patients' urine every 4 hours?
before operation. Again, before, right?
Must have his urine tested 4 hours after operation.
False.
We've not,
False.
not any clinician, none of you have ever seen us doing this.
Yes, sir. False.
False, sir.
So be
Oh, I
put
kept going.
on routine antibiotics to prevent infection.
Yes. True.
True.
Everybody will say it's true. I want somebody to say it's false. Then you now defend your answer. We are not doing group discussion. I don't know what is happening.
False, sir.
Yes, one brave and confident guy said false. Who is that person?
Passion, sir.
Let me give you a gift. The gift is just sweet too. Don't think it's a textbook or.
Thank you, sir.
So tell us why it's false.
So we usually give prophylactic antibiotics.
Excellent. God, this guy is a surgeon.
Yes, sir.
It's not routine, it's prophylactic to prevent. You see, all of you are just saying true. So it's prophylactic antibiotics, and it's just a single dose you give, except when what happens? When will you add a second dose? Hello? When will you add a second dose of you give prophylactic antibiotic at induction of anesthesia so that the blood coming out when you make your incision has achieved MCI, minimal inhibitory concentration. There's antibiotic in that blood that is coming out. So you give prophylactic at induction of anesthesia. Dr. Hashim, when will you want to repeat a second dose of prophylactic antibiotic?
Sir, if the surgery lasts more than 4 hours, and I will give a second dose.
3 or 4 hours, which one?
4 hours, 4 hours, sir.
You all agree, is it 3 or 4 hours? Me, my brain is reading
It's
3
4 hours.
4 hours. Are you sure? It's not 3 hours.
I don't
Okay,
think it's up to 4 hours.
I thought it's 3 hours. If the
It's 4 hours.
you are sure? Don't
Yes,
mislead
sir.
us. Oh.
So we'll check. We'll check, sir. It's
Just in my
3
brain,
hours.
I'm just recalling 3 hours.
Yeah. Any
Okay. That is one. When the procedure will exceed 3 hours, you want to give a second dose. Yes. What again? Because
When there's excessive
one,
blood loss.
when there is excessive blood loss. Excellent. Why is that so? You see, I've ticked something here. You know, when you are losing the blood, you are losing the antibiotic. Is that not so? And at the same time,
Yes.
the body is metabolizing, it's taking its effects. So the concentration is reduced. So you have to reduce. You have lost a lot of blood, you have lost a lot of antibiotics. Dr. Fatima, I'm really impressed. Too. You are reading. Yes. Let me go back. Is there any other reason you want to repeat a dose? Okay, let's assume there is none, even though I know there is. Yes, in a patient with typhoid perforation, which of the following may cause cardiac arrest? Okay, typhoid perforation. I think everybody should know this answer. Cause cardiac arrests or affect reversal. Oh, the answer is there. Reversal of muscle relaxation after operation, if it is not corrected before operation. A, hyponatremia. B, hypochloremia. C, hypokalemia. D, dehydration. E, anemia.
Hypokalemia.
Hypokalemia.
Yeah, everybody.
Hypokalemia.
Not just the answer. What is the reason? Yes, you want to tell us the reason?
Internal fluid shift.
Yes, any other reason that is tenable?
Okay, so potassium is required to stabilize the membrane. So when there is hypokalemia, the membrane is not stabilized as such. There will be difficulty reversing the muscle. The anesthetic agent.
Not only that, even in the heart, it causes, like, if you have lack of stability and contractility, what happens? They cause arrhythmias. Is that not so? And arrhythmias progresses to cardiac arrest. And the cardiac arrest is at diastole. Is that not so? Yes. Then for this, muscle relaxation is prolonged. You take patient to the ward and they relapse into muscle relaxation and they cannot breathe. You just go and meet a dead patient. Please don't take a patient with hypokalemia to surgery until it is corrected. You see, let me tease the ONG people. They used to tease us that surgeons don't have emergencies. They have to correct hypokalemia, they have to correct electrolyte before taking patients to surgery. We are on fetal distress. We just go and do CCS. That is emergency. Yes, they will be teasing us. Why will you say it's emergency and you are keeping patients in the ward for 3 days correcting hypokalemia? I'll just smile and say, yes, we don't have emergency. But don't forget, yes, the best surgeon is the one who knows when not to operate. We are own emergencies. Our surgeries are either classified as, I hope you've all reviewed our lecture on perioperative care, where we classified surgeries into urgent, into emergency and elective. Like emergency, you don't have time to correct any derangement. Somebody comes in with ruptured aortic aneurysm. Which kind of electrolyte do you want to correct? That is an emergency, completely obstructed airway. You just go and do that. Okay? Tension pneumothorax. But urgents, most of the surgeries that come to our A&E are not emergencies. Okay? They are what? Urgent. You stabilize them, correct derangements, then you take patients to surgery. Then elective will require full preparation of the patient. So we have done lecture on fluid and electrolytes. You go and read hypokalemia, the ECG changes and all that. Now, classification. According to the classification of the American Society of Anesthesiologists. Wait, this class is so quiet. Am I alone?
No, sir, I don't alone. We're
No,
all
sir.
here.
No, sir.
Everybody is
No,
just
sir.
as if I'm in a graveyard. A, with gastric outlet obstruction is 4. B, with hemoglobin of about 10 grams per DL, but with no symptoms of breathlessness is 3. With respiratory obstruction for a foreign body is 2. With SS, sickle cell, okay, or SC disease is 3. E, who is moribund and is not expected to live 24 hours with or without surgery is 6. Yes? Who wants to grade the ASA for us? American Society of Anesthesiologists, ASA 1 to 6. Who wants to try? I'm not saying you should get it correctly, just stimulate your brain. Who wants to try?
See, it's true.
No, let's come back. I'm asking who wants to try? Before we go back to the question, who wants to grade?
Okay, so let me try.
Okay.
Okay, ASA 1 is a normal fit patient. ASA 2 is a patient with mild systemic disease, such as hemoglobin of 10 grams per DL, but no symptoms. And then a hypertensive or diabetic patient that is stable is also classified as ASA 2. ASA 3 is a patient with severe systemic disease that limits activity but is not incapacitating. Example is gastric outlet obstruction. And ASA 4 is a patient with an incapacitating systemic disease that is a constant threat to life, e.g. respiratory obstruction. ASA 5 is a moribund patient not expected to live 24 hours with or without surgery. Then ASA 6 is a brain death patient.
Yeah, that's excellent. So let's go back to the question. I'm going to highlight the table for you to see, but what is our answer? Yeah. Somebody was attempting to answer. Yes, you can answer now.
Okay, A is false.
There was somebody that was trying to answer that, trying to say something. He has run away. Who was trying to answer? Is it Umar? Umar, where are you? I saw you leave. He was trying to dodge. Yes, what was the answer you chose? Why did you run away? You initially wanted to answer.
I said D is false, I think.
Okay, let's start from A. A is what?
A is false.
No, allow Umar to answer.
Oh, okay.
A is false. Of course, healthy patient is not a healthy patient.
A is false. Yes, correct. What of B? Okay.
False as well.
Let me show you something. so that I think we have I believe there is a table here, which all of you should have, please, so that you master this ASA grading. There are various grading systems, but however, this ASA is the common one that is commonly used. I told you the other day that there are several grading systems, and ASA is the one commonly used. Yes. Can you see it?
Yes.
Yes, sir.
Yeah. Okay. ASA, and this is the definition of the patient status. ASA 1 is a normal, healthy patient. ASA 2, mild systemic disease, okay? Like a controlled hypertension. If you use hypertension as an example here, patient has a controlled hypertension, okay? Then ASA 3, severe systemic disease. This one is uncontrolled hypertension, okay? Then ASA 4, severe systemic disease that is constant threat to life. For example, that severe hypertension now develops stroke. We are using hypertension as an example. You see, that stroke is a constant threat to life. ASA 5, moribund, not expected to survive without operation. Okay. Maybe he has had one massive intracerebral hemorrhage with raised intracranial pressure. Okay. You can't just say, okay, let me continue. You want to reduce that maybe by evacuation or by putting an extra ventricle, whatsoever the neurosurgeon wants to do. And ASA 6, declaring brain dead. So I think you should all be conversant with these grading. Now, ASA 4, gastric outlet obstruction is not a constant threat to life. Okay. With hemoglobin of 10, with no symptoms of breathlessness. Okay. It's 3. Is this a severe systemic disease?
No, it's false.
False.
It falls under 2. It's a mild systemic disease.
Yes, because hemoglobin is 10, or even though it's low, and no breathlessness. It's anemia without breathlessness. It's a mild systemic disease. If this hemoglobin is 10 and patient is breathless, that is severe systemic disease. Now, with respiratory obstruction from a foreign body, they said it's mild. Is this true?
It's false.
What is
It's
this?
ASA 4. It's ASA 4.
It's
Yes.
constant threat to life.
False.
Now, what of a sickler? It's a severe systemic disease. Is that not so?
Yes.
True.
Yes. But when they now have complication, it will now become a constant threat to life. Now, E,
Yes.
who is moribund and is not expected to live 24 with or without operation, is ASA what?
It's 5.
5. Excellent. You guys have understood the ASA classification. Okay. So let's proceed. In the perioperative management of a patient, anesthesia can be started with 1 cylinder of oxygen on the anesthetic machine. Is it true?
It's false.
Why is that?
Two oxygen cylinders are required.
Why?
Okay, 2 oxygen cylinders are required. Either both of them are full or one is half full, so that in case one finishes, you can quickly switch to the second one without much delay.
I always remember this story. You know, in the preoperative check of anesthesia, anesthetist is supposed to check the machine before even starting anything. You're supposed to do a machine check. So I have one anesthetic machine that we operate with. It's working perfectly. And that anesthetist is used to that machine. So routinely when he came for that operation, he did not check the machine. We just lay the patient down. He just gave muscle relaxation. He wants to on the gas and it got stuck. He has paralyzed the patient. He cannot put on the gas to maintain the patient on anesthesia. So don't think that all these things, just overnight, the cap got crusted and the machine refused to work. And we're running into trouble. If it was not an experienced anesthetist, so we'll have run into trouble. So you have to check your machine. Now, don't say, okay, let's start with this oxygen. It's halfway. It's just a lipoma excision. Let me give you an interesting story. During my operation list in one teaching hospital like this, so the matron came in with a friend that, okay, please, this patient has a ganglion cyst. Can we just interrupt your list a little and just excise it? I say, no problem. It's your patient. Let's go ahead. Is it not just ganglion cyst excision? That ganglion cyst was right on her radial artery.
Oh my God.
During the procedure, we saw blood on the ceiling. So don't ever say it's just this small lipoma. Let's just use HABA. This is not just this small. Let's use half of the cylinder. So that operation that we're saying is 5 to 10 minutes to cost like 1.5 hours. In fact, what I just did, I just ruptured the cyst. I forgot about ganglion. Nobody is talking about ganglion cyst again. We just ruptured it and expressed the contents and continued a major operation. So don't underestimate a procedure. So you must have 2 full cylinders, please, minimum. Okay, and even there's one small emergency cylinder that is behind the anesthetic machine. That's also should be present. Don't ever start with 1 cylinder. It is advisable for the person conducting the anesthesia to prepare the intravenous agent himself. True or false?
True.
It's true.
Okay, so this is false. This is true. So you know a label, you know all the whatsoever you have there. There is no need for an assistant when anesthesia is being induced.
False.
False.
There's always need for an
Even to pass
assistant.
catheter, you need an assistant. Nothing. The vein at the back of the hand is always preferable to the one at the forearm for setting up a drip. True or false?
False.
Why is it false?
Okay, the veins at the back of the hand, they are prone to vasoconstriction quickly.
Why?
So the ones in the forearm are more preferred.
That is one reason why. Why are they prone to vasoconstriction compared to
Okay,
the
okay,
one?
sir, because of their sizes, they are quite small.
They are smaller than the one. So it's because of the caliber and because of what?
Movement, I'm not sure.
Okay. Now, which vein do you think is closer to the heart?
The cephalic vein.
No, between the forearm vein and the one in the forearm, the one in the back of the hand.
Okay, the one in the forearm.
Yeah, so what happens? Which one is prone to tend to receive more blood? The one in the forearm, it has bigger
Yes,
has more flow, okay? Less prone to vasoconstriction. Now, in fact, when you are resuscitating patients in shock, it's preferably use both anticubital vein because of their caliber. They have bigger caliber, bigger flow rate, less prone to constriction. The rate of infusion can safely be increased by squeezing the plastic container.
yes, true.
Yes, you want to increase it. You can squeeze to increase the rate. In the anesthetized patient in supine position. Yes, this is a very important question because sometimes you see somebody is performing surgery and the leg of that patient is crossed and he's just there lavishing his procedure. Or somebody's hand is dangling. After the procedure, you have destroyed all his brachial plexus. On all the leg is a tall person. The legs are long, he's longer than the operation table. And his calf just as his ankle is dangling at the edge of the bed. So what you need to know when you are positioning patients, you want to avoid some following factors. One, stasis. Anything that will cause stasis to prevent what? DVT. Two, you want to prevent nerve compression. Three, you want to prevent excessive traction. Four, okay, you want to prevent nerve injury disruption. Is still as compression, but sometimes it's not compression now, you are causing just injury, maybe due to you are disrupting a nerve injury. If a patient is lying and crossing the leg, you are causing stasis of the calf muscle, and that patient can be prone to developing DVT. Okay? And when the hand is dangling below the bed, below the level of the patient, he might have brachial plexus injury. Okay? If you are placing the arm above the level of the body, maybe on an armrest, you are placing too much traction on that limb. Yes, if the patient is longer than that table, you might be compressing it now. You might have to add attachment to that bed. So let's come to this question. In an anesthetized patient in the supine position, the legs may be crossed if necessary. True or false?
It's false.
This is false, please. If the arm is not used for infusion, the hand may be placed under the buttock.
It's false.
It's false.
It's advocated that you place it on the chest.
Yes, if Okay. If it is necessary to use an arm board for infusion, the arm should not be higher than the shoulder to prevent traction on the brachial plexus.
Yes, it's true.
Okay. There is no need for any measure if the patient is longer than the table.
It's false.
The kidney bridge can be used.
True.
What is kidney bridge? You see, I did not write true or false because this line can go for false, it can go for true. So which one? What is kidney bridge? Okay, let me allow you to go and check. But the answer there is false. Now, in the lateral position, the tidal volume is not affected. True or false? Patient is
False.
naturally, it's going to compress on the lungs on that side. So his tidal volume will be affected. So this is false. Is that not so? B, there is increased ventilation and increased perfusion of the upper lobe.
False. Oh, sorry. Wait. I think it's decreased ventilation, increased perfusion of the upper lobe.
Patient lateral position, there is increased ventilation and increased perfusion of the upper lobe. True or false?
False.
False, correct. C, there is decreased ventilation and increased perfusion of the lower lobe. True or false?
True.
True. Retention of carbon dioxide may occur if the patient breathes spontaneously.
It's true.
Yes, so you have to
True.
stop breathing because you are compressing the lungs there. The kidney bridge does not affect breathing. You see this kidney bridge is following us. What is kidney bridge?
No idea, sir. We'll check it up.
Assignments. Concerning the position of anesthetized patient. You guys are not talking. I'm tired. Why is the class so quiet? Let me start picking on people. Let me be seeing your names. Yes. Who wants to read this? Aminu Isa. Aminu Isa, are you with us? Read the question. He said good afternoon. It's evening. Read the question.
Concerning the position of the anesthetized patient. A, the tidal volume is decreased by the prone position, but not by the stiff Trendelenburg position. Venous bleeding is less than the intracranial pressure low in the sitting position. C, there is a tendency to hypertension in the sitting position. D, the stiff Trendelenburg position may cause cerebral edema. E, in the prone position, a firm pillow must be placed under the shoulders and another under the abdomen.
Okay, at least you have said something. Now I know I'm not alone. Okay. Concerning the position of the anesthetized patient, the tidal volume is decreased by the prone position, but not by steep Trendelenburg position. True or false?
It's false.
Why?
The Trendelenburg position actually decreases the tidal volume.
Yes, because if
the patient's head will be down.
Yes, the legs are up.
And the head is down.
Don't mind my drawing. This is how we used to draw in private school. This is the head. So this Trendelenburg position. So of course, the tidal volume will reduce. Reverse Trendelenburg is like this. Is that not so? So if you are doing Trendelenburg, the tidal volume, the long volume, see this guy is having lungs, will reduce. Now, venous bleeding is less and intracranial pressure low in the sitting position. True or false?
It's true.
Venous bleeding is less. Now, you see, neurosurgeons, sometimes they do their operation in a sitting position, maybe in posterior cranial fossa tumors, where the bleeding will be less, because if the patient is seated, there is drainage downward from their operating site, so bleeding is less. And the intracranial pressure is low in a sitting position, of course, because the cerebral perfusion pressure will reduce. This is the advantage. However, the disadvantage is more than the advantage. By the way, this is true. It doesn't mean sitting position doesn't have its own disadvantage, because if patient is seated, there is vasodilatation downward and pulling of the blood to the lower limb, and there is stasis. And when there is stasis, the patient is prone to developing what? TVT. And this disadvantage is even more than the advantage of reduced blood loss. So you can place patients in a prone position if you want to do surgery in the posterior cranial fossa to avoid this risk of TVT. So you should know that sometimes procedures in head and neck, the patients might be elevated 15 degrees head up, so that the venous drainage will be improved, which will reduce bleeding. If patient is seated, you should know that the bleeding is reduced if you are operating in the head, but that patient stand a risk of developing DVT. Now, C says there is tendency to hypertension in sitting position. True or false?
It's false, because there's pulling of blood to the lower limb, so the patient is at risk of hypotension, not hypertension.
Not hypertension. Excellent.
False.
The steep Trendelenburg position may cause cerebral edema. True or false?
It's true.
It's true. Look at our Trendelenburg. This is our animation. It's showing Trendelenburg. So D is true. In the prone position, a firm pillow must be placed under the shoulders and under the abdomen. True or false? Let's draw our animation again. Let's assume this is his, okay, let's say he has a beak now, so that we know where the positioning is. And you have the abdomen. You see he has eaten swallow. He has pot belly. This is the lower limbs. This is a prone position. Now this question is saying you put a pillow here, and you put pillow. Look at this pot belly. Now you now put pillow here again. What will happen? He can't breathe. Patient in prone position, you always put pillow at the hip so that this pot belly will have respiratory excursion. So it's under the hip and under the chest.
The shoulder.
Yes, the shoulder. So that the stomach, the abdomen will be free. Okay. So this question is false. It's not under the abdomen, it's under the hip. Is it clear?
Yes.
In the monitoring of the anesthetized patient, the cause of a rise and fall of more than 15 millimeters of mercury from the resting blood pressure should be found. Cardiac failure is the likely cause of high CVP, central venous pressure, and hypotension. C, a collapse and immobile reservoir bag while the patient is breathing suggests airway obstruction.
Yes, sir, it's true. Option C is true.
Colorimetric method of estimating blood loss can be done during operation. The respiratory rate should be between 15 to 30. This question is quite tough. Oh, is it not tough?
It's very
Very tough, sir.
Because I'm just seeing, but let's analyze it, even though it's tough. That is how your books, your tropical books are. Okay. In monitoring, now this is monitoring of anesthetized patients. A says the cause of a rise or fall of more than 15 from the resting blood pressure should be found.
Say false.
Why is it false?
Because you should expect the blood pressure to rise post-surgery because the body is trying to raise the blood pressure on its own.
Look at this.
Anesthesia.
You know, some anesthetic drug will cause what? Hypotension.
Yes.
Okay. Some anesthetic drug will cause hypertension. Okay. So the cause might just be from your drugs. If you are using Halotin, the blood pressure goes down. If you are using ketamine, the blood pressure goes up. Now, cardiac failure is likely cause of high central venous pressure and hypotension, true or false? Now, let me explain something to you about this central venous pressure and the heart itself. Now, when you see a patient with reduced central venous pressure, you know, during monitoring of an anesthetized patient, you can pass central venous line and monitor the central venous pressure. Is that so?
Yes.
Now, in a patient with low central venous pressure and hypotension, it means that patient is losing blood.
Mm-hmm.
In a patient with high central venous pressure and hypotension, it means the heart is not pumping. Do you understand? Is it clear?
Yes, sir.
Clear or confusing?
Can you explain it again, please?
Okay. In a patient with central venous pressure, ideally, it tells you the volume of the blood the heart is accumulating. Ideally, it's a measure of that. Now, when the central venous pressure is low, and at the same time, the blood pressure is low, the BP is low, it means there is no blood in that heart. It means that patient is losing blood. Is it clear? Now, if the central venous pressure is high and the BP is low, it means the heart is not pumping. Is it clear? Because the central venous pressure is a measure of the amount of blood in the heart at a time. It's low, there is no blood in the heart, and the BP is low. That means patient is losing blood. It's high, there is blood in the heart, and the BP is low, it means that heart is not pumping. That's why the BP is low. If you remember your physiology, blood pressure is equal to what? Now, wow.
Heart rate multiplied by stroke volume. I think, not sure.
Now, wow. Blood pressure is equal to what?
Heart rate multiplied by stroke volume.
The stroke volume multiplied by peripheral resistance.
Yeah.
Yes, sorry.
Stroke volume multiplied by
Peripheral resistance.
Okay. Now, if this stroke volume is low, it means there's no blood in the heart. Go.
Yes.
What will happen to the central venous pressure? It's going to
also decrease.
Yes. So if this is high, it means there's blood in the heart, so it can pump adequate stroke volume. What will happen to the central venous pressure?
It will also be high.
Okay, now what I'm saying here, this patient has low central venous pressure and the BP is low. It means that patient is losing blood. There is no blood in the heart and the peripheral resistance is still low. If this is high, there is blood in the heart and the BP is still low, it means that heart is not pumping. That's why the BP is low, because the heart needs to pump to get a good stroke volume so that the BP will rise. Please, if you don't understand our physiology, go and read. So, I've even forgotten the question. What are we even discussing? Because you guys allow only me to be talking.
Sorry, sir.
Hashim, so you are here.
Yes, sir.
You are eating food, go.
No, I'm just listening to the discussion.
You are confused also.
Partially, but it's clear now.
Go and read, my friend.
So the explanation is okay for now.
It's okay. So where are we?
C.
So is C, B, is it true or false?
It's true.
You all agree with him?
Yes.
Cardiac failure is likely to cause high. It is what I've been explaining now. Okay.
Yes, I've been explaining. Yes, sir.
C, a collapse and immobile reservoir bag while the patient is breathing suggests airway obstruction. True or false? C.
True.
That person, the way she mentioned it is not with confidence. A collapsed and immobile reservoir bag, that bag that patient is breathing in under anesthesia, while the patient is breathing, suggests airway obstruction. True or false?
True.
Collapse, immobile bag, while the patient is breathing, suggests airway obstruction. What of if you close the valve? If you close the valve, what will happen? It will not be.
There'll be no air. There'll be no air into the bag, so it will collapse.
Now, wow, True or false? Is it true or false? You see, my pointer is okay. Let me allow you, since you don't.
Okay, sir, it's false. Okay, it's false. It's false, not true. Since the patient is breathing, maybe there was a leak or something. So
Colorimetric method of estimating blood loss. I know some of you, this question have made you slept. Colorimetric method of estimating blood loss can be done during operation.
it's false.
Why is it?
It's done at the end of surgery.
Yes, because you have
when you have all the gauze that has been used and the abdomen, that's when you do it. You estimate the blood loss.
Yes, galvanometric method can be done during surgery because it's an estimation of the difference between wet and dry gauze. You have a preformed information of the dry gauze. Then after it is wet with blood, soaked with blood, you now take the difference. You can do that during surgery. While galvanometric method is to estimate the hemoglobin of that blood that is lost, all the hemoglobin for that procedure. So it has to be after the surgery, all the blood collected. So not during. Respiratory rate should be between 12 to 30. True or false?
False.
False.
Okay, what rate?
16
12 to
12
to 24.
I think 16.
Is it 12 or 16?
16.
16 to 24. So what is the problem if you have less than 12? What will it lead to? Patient is not breathing well. What will it lead to? Yes?
It can be airway obstruction.
No. Just
it can lead to hypoxia.
Is it hypoxia or hypercapnia? Now, if patient is not breathing well, you know the carbon dioxide will accumulate. Is that not?
Yes.
And it's because what type of acidosis? Is it respiratory acidosis or metabolic acidosis?
Respiratory acidosis.
Respiratory acidosis.
Dioxide are accumulating. Now, if the patient is breathing faster than 24, what will happen? They are giving out too much carbon dioxide. It will lead to a respiratory what?
Alkalosis.
Alkalosis.
So all those effects you are expecting in acidosis and alkalosis. I'm talking too much. Who else wants to read? Where's Jamilu Ibrahim Ahmed? Where are you? Jamilu Ibrahim Ahmed. You see, he's not even with us. So. Where is Nuruddin Umar Zakari? You see, he just logged in and ran away. I'll be taking snapshots.
I'm there.
Yes, read the question. You see,
Okay,
Jamilu Ibrahim is not with us. He just logged in and ran away.
Okay. In the anesthetized SS or SC patients, A, oxygen given should be 50% if the hemoglobin is less than 8 grams per deciliter. B, the transfusion trigger can be 8.0 grams per deciliter. C, an intravenous infusion should always be set up. D, it is not essential to replace blood as it is lost. E, transfused blood should be as fresh as possible.
That is good. So, what is our answer? Who wants to attempt? A, true or false?
True.
Why do you say true?
Yeah, for a sickle cell patient, I think you have to give them 50%, whatever like the hemoglobin level is.
Yes.
Right?
SC. Oxygen giving should be 50% if hemoglobin is less than 8 grams per day. Is that true? Is it 50% you give them or 100%? Or even less than 50%? Is it less than 50% or more than 50%?
Those are for sickle cell patient is 50% that we give, 50% oxygen.
Depending on whatsoever the hemoglobin is.
Yes, whatever the hemoglobin level is.
So the answer is true.
Yes.
Okay. B. Transfusion trigger can be 8 grams per DL. True or false? Hashim,
Sir,
you are quiet.
so usually it depends on the steady state hemoglobin of the patient. But I can go for true, sir, with this one.
Yes, it's got. What is transfusion trigger?
The hemoglobin level at which you must transfuse before surgery.
Eh? Must it be surgery?
No, not just transfusions. At the level at which you must just transfuse the patient to maintain adequate tissue perfusion.
Okay.
Yes,
now,
sir.
for sickler, how is it? How will you determine a steady state in a sickler? That is the first question. The second question, what is the transfusion trigger for a normal adult male?
Okay.
The first question, steady state hemoglobin of a sickle cell disease patient.
So it depends on the individual, but usually it's around 7 grams per DL.
No, you did not answer the first question. That is the second question you are answering.
Okay.
What is a steady state hemoglobin for a sickle cell disease patient?
Okay, so is the normal hemoglobin levels for a healthy sickle cell disease patient.
This is your definition. Where did you read it from? Yes, who want to tell us what is a steady state hemoglobin of a sickle cell disease patient? You see this can be embarrassing. When a sickler comes to meet you as a doctor and is telling you that his steady state hemoglobin is 8 grams per DL, and you don't have idea of what he's saying, you are in trouble. Yes?
So the steady state is the level of hemoglobin in which the patient can function, and it's individualized for each person, for each patient. It's not the same for all of them.
Wow. Should I give you an assignment?
No, sir.
You see, sickle cell disease patient, okay? You know they undergo frequent crises, is that not so?
Yes,
yes.
When they undergo crisis, they might have drop in hemoglobin. They might require transfusion to stabilize them. Is that not so? Sometimes they might have a very low hemoglobin for a very long time without undergoing transfusion, without undergoing crisis for up to 6 months. Even though you go and do the HB and you see it's 6, don't say, hey, this guy is really pale, let me go and transfuse. If he maintained this hemoglobin for up to 6 months without crisis, without transfusion, that is a steady state. Is a steady hemoglobin of a sickle cell disease patient for which Patient does not receive transfusion in the past 6 months. That is a steady state. So you should know that. Now, what of the second question, Dr. Hashin? I've not forgotten. What is transfusion trigger?
So the level of hemoglobin below the steady state that will necessitate transfusion.
Yes, that is it. The minimum HP. Okay. Below which transfusion is required. And WHO definition for steady state is what? WHO criteria for steady state hemoglobin is how much?
I think 7.
Yes, 7
Not
grams.
sure.
Yeah.
Yes, sir.
7 grams per DL. That is WHO. When HB falls below this, you have to transfuse. Okay. Now, but generally it's used, 8 is used, 8 grams per DL. But the WHO have given a standard steady state that when HB falls below 7 grams per DL, that patient should be transfused. But you know, this steady state varies between individuals, depending on whether it's a child, neonates, whether it's an adult or elderly. Generally, you know, for children, you transfuse volume by volume. Is that also? What do you mean volume by volume? You don't want patients to lose blood. As they lose blood, you transfuse them because they are prone to developing heart failure. Now, for elderly patients, also, you have to be very careful with their transfusion. So their transfusion trigger varies. If you are using percentage, you say when an adult have lost 20% of their total blood volume, you have to transfuse. It's a transfusion trigger. Okay. But this varies. In elderly patients, you can't use that because of their comorbidity, their physiological changes of the cardiovascular system. So it's between 10 to 20. But for adults, when it's more than 20, greater than 20%, adults between 10 to 20% in elderly. So our question here, we've deviated so much. Yes, it's a transfusion trigger can be 8 grams per day. Let me tell you something. Sometimes a patient might have hemoglobin, can be anemic without the compensation. You can see a sickle cell disease patient with anemia. It's not decompensating. It's not having anemic heart failure. You don't need to transfuse. You might see patients with even a higher PCV developing the anemic heart failure, then you transfuse now. An intravenous infusion should always be set up.
Yes, it's true.
Should always be set up.
Yes, true.
I'm just saying always so that I will confuse you. In some cases, always is true. In sickle cell patient, don't go and predispose them to crisis. If you leave them dehydrated, they will just develop crisis and you'll be in trouble. So you must always be set up for a sickler. And when you are giving infusion, you have to give them warm fluid. Don't go and just start infusing cold. You have to prevent factors that cause crisis in sickle cell disease patients. The extremes of temperature, dehydration, okay. What again?
Acidosis can also trigger a crisis.
Okay. It is not essential
Yeah, that's fine.
as it is lost. True or false? It is not
Um,
essential to replace blood as it is lost.
false.
It's false. Transfusion should be transfused blood should be as fresh as possible.
True.
Yeah, true. So you should know those percentages for AS. I will use 30%. Okay. If the HB is 10, 30% oxygen. Okay, you give 30% to AS patient but for sickle cell disease, the minimum you can give is 50%
50%.
the HB level. The minimum. Not gone anywhere. We are only in number 15. Should we be fast? Just be mentioning true or false?
Those
No,
are the
sir.
explanation is more important to us.
Yes, to help us to
Apply it in
remember.
other places. It's not how many we've done.
Okay, okay.
Oh, yes.
Hypotension, I'll give you the slide after so that you continue because I'm the only one talking here.
Yes, sir.
Some are even sleeping. I believe if I call all these names, less than 50% are here. They just logged in and ran away. Let me demonstrate that. Where is Halima? You see that?
Yes.
Okay. Let me see if Jamilu is back. Where's Jamilu Ibrahim Ahmed? This is a confirmation that he has not been with us throughout.
Maybe he fell asleep.
Yeah, he's sleeping. Where is Nusaiba Abdullahi?
Sir, I'm here.
Okay, okay. Where is Hafsat Idris?
I'm here, sir.
Okay. I said less than 50%. Where is Aminu Isa? You see?
Sir, I'm here.
Aisha Abdullahi.
I'm here. I did not go anywhere.
Wait, who is this DBB? You see?
I'm here, sir.
Who is DBB? Who are you?
I'm Ahmad, sir. My name is Ahmad.
Hope you are not a hacker. You are using
No, sir. No, it's Dr. Baba, sir.
Okay. Okay. Jamil, you are well now. Okay. Hypotension.
Yes, Chief, I'm here. Yes.
Perioperative period may be caused by, yes, this is a very good question. Causes of hypotension in the perioperative period may be caused by A, early carbon dioxide retention, B, vagal inhibition, C, mismatched blood transfusion, D, reaction to pain or fear, E, anesthetic agents. A, true or false?
False.
Why is it false?
I think that's in hypertension rather than hypotension.
You agree with her? You see, all of you.
Yes. Yes, we agree with her.
Okay. Early carbon dioxide. Early carbon dioxide retention. Why is this early here? Is there any implication? That means late must have implication. Dr. Hashim, are you thinking what I'm thinking?
Sir?
I say, why is that early there?
I can't remember.
Do you know before? If you say you can't remember, that means you forgot. I'm just asking. They said early carbon dioxide retention. It means there's an implication.
Yes, sir. Maybe initially it will cause hypertension before the hypertension.
Okay, let's continue. Vagal inhibition. What does vagal inhibition does? Hypo or hypertension?
Hypo.
Hypotension.
Okay. Mismatched blood transfusion.
True.
It causes what?
It causes hypotension.
Why now? Why does mismatched blood cause hypotension?
There can be reaction due to the mismatched blood. This will lead to increased permeability, vasodilation due to release of inflammatory substances in the blood.
Yes. The inflammatory mediators will cause what?
It will cause vasodilation and increased cellular permeability.
So when there's peripheral vasodilation, there will be
there will be hypotension.
Okay. Yeah, so that is reaction to pain or fear. What does it cause?
Hypertension, sir.
Which one, hypo or hyper?
Hyper.
So this is false, Kenan.
Yes.
Yes, what again? Anesthetic agent. Like which one? Hypotension, yes. True or false?
Halothane, yes. True.
Okay.
So, but the PISA,
What?
the vagal inhibition.
Yes. What does it cause? Hypo or hypertension?
Hypertension.
So how does it do that?
Uninhibited parasympathetic activity. Increase ionotrope and chronotrope.
We don't get that explanation.
Okay. So the force of contraction of the heart, the rate will be increased if there's vagal inhibition. So that will increase the blood pressure. Since the blood pressure is a function of systolic volume and peripheral resistance.
Vagal.
Also,
vagal is what? Parasympathetic.
Yes, sir.
Parasympathetic. I was wondering how B is correct. Why is B true?
So you are the one that says true now.
So the answer is false.
Yeah, we said true. It's false. It should be false. I was actually checking it now because if the vagus is inhibited, it cause hypertension, not hypotension.
Yeah, so this is false.
It's false.
Yeah, this is false. Because if you inhibit the parasympathetic, that means there will be sympathetic outflow, which is causing vasoconstriction. And when there is increased vasoconstriction, it translates to what? Peripheral resistance that causes
hypertension.
Hypertension.
False.
Yeah. Hashim has woken up. Yeah. Now, but is there situations where vagal inhibition can cause hypotension?
Maybe the vagal maneuver. I'm not sure.
Yes, what happens in vagal maneuver?
Vagal maneuver is when you put pressure on the neck to bring the heart system back to normal.
What is this thing? No, you have to be clear.
Vagal maneuver usually is applied when pressure is placed to the neck, because that's where the vagus nerve is, so that the heart rate can return to normal.
What do you mean by normal? Is it increasing or reducing? Just big.
No, in the case like the patient has tachycardia, it can slow down the heart rate.
Now, what you need to understand, okay, what causes hypotension generally? The commonest cause of hypotension in surgical patients is volume loss, volume depletion. Is that not so?
Yes, sir.
Maybe there's blood loss. Now, there are some certain situations where there is adequate volume in the in the intravascular space, but there's hypotension. Do you understand? So it is in those situations you have vasovagal or viscerocardiac reflex. In vagal inhibition will cause hypotension. In situations like what she just mentioned and what is called viscerocardiac reflex. So there are some reflexes where inhibiting the vagus could cause hypotension even though there is adequate circulating blood volume. For example, when you stretch the rectum, what happens? Or anal canal. Overstretching of the rectum. Where is Hashim?
Sir?
When you overstretch the rectum, maybe you are doing anal dilatation without adequate analgesia. What happens?
There's I can't.
You see
I don't know.
that is a viscerocardiac reflex. You are inhibiting vagus, and is a vagal inhibition, where it's a form of reflex that can cause cardiac arrest. Okay, so read about viscerocardiac reflex. There are
So, sir, it falls under hypotension here. Since you're just explaining this and it's saying like vagal inhibition, viscerocardial reflexes, right? So if you're giving
In
an
that
MCQ,
case,
you're going to choose like B as true rather than false, right?
Yes.
it can be true or false then, B.
Yes, because
You
now
need to rephrase the question more, since it could be either of the two.
hypotension in the perioperative period it doesn't need to, may be caused by vagal inhibition, so it's true.
Okay.
Maybe in this form, in visceral reflex, they may have hypotension. Okay, because excessive stretching and inhibition of the in that stretching of that mucosa, the pulse rate, there will be severe pain, there will be excessive the pulse rate and that reflex will just top the pulse rate and there will be sudden cessation of cardiac activity. Patient will go into cardiac arrest. Well, just read about visceral cardiac reflex. Vagal inhibition. Look at this next question. I even answered it. Vagal inhibition, visceral cardiac reflex results from cessation of respiration and fast hearts. If the heartbeat can be hard, B, may be caused by dilation of the anus and cervix, does not lead to cardiac arrest, may be treated by deepening of the anesthesia. So this is true, this is true, this is false. May be prevented by treated by intravenous injection of atropine. True or false? Yes?
True.
True, sir.
Yeah. Because atropine will further increase the heart rate, go?
Yes, sir.
Yeah. Hey, is it true or false?
It's false.
Cardiac arrest during operation may be caused by cardiac arrest during operation. By the way, who can define what cardiac arrest is?
Cardiac arrest can be defined as total cessation of all heart activities.
This sudden cessation.
Yes, sudden cessation of all cardiac activities.
Okay. So what can cause it? Increase release of catecholamine and hypoxia from asphyxia.
Yes, true.
Okay. Asphyxia causes, hypoxia causes cardiac arrest. Excessive blood loss causes cardiac arrest.
True.
Hyponatremia. Hmm?
True.
You see, I did not hear. Is it true or false? Hyponatremia.
It's true. Electrolyte imbalance causes cardiac arrest.
Not electrolyte. I did not say electrolyte. Neither did the option says electrolyte imbalance. It says hyponatremia.
I'm not sure. I think it's false.
No. Just tell us. Who knows, true or false? And the reason behind that. So this is false. You know, it's cerebral edema, it will be causing. It's hypokalemia that will cause cardiac, or hypocalcemia, or hypocalcemia, or hypocalcemia.
What
Myocardial,
about hyperkalemia?
it can also cause now. Both can cause.
So in kalemia, hyper, same
Yeah.
outcome.
Okay. Cerebral, they go along with water. Yes. D, myocardial infarction.
True.
Hyperventilation. You know, acidosis is caused by hyperventilation. And this leads to cardiac arrest. Why? Hypoventilation leads to acidosis. Why hyperventilation leads to alkalosis? Because you are giving off all the carbon dioxide. So does it lead to cardiac arrest?
False.
So it's false. So your answer here, you know, during that time when you are answering using HB pencil, if you are not sure of an answer, you just do like this. They'll just mark it wrong. Next question. Inflation and deflation of an anesthetized patient with an endotracheal tube are difficult. Possible causes are A, extended neck, B, in the endotracheal tube, blood in the endotracheal tube, pressure on the trachea from without, hypocapnia, prior regurgitation, or vomiting. Which one is true? Which one is false? Just be mentioning, let me be ticking. A. True or false?
False.
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 B. True. There's blood.
True.
It will not deflate. C.
True.
Ha. D. D.
False.
E.
False.
Prior regurgitation or vomiting.
True.
It's
It's
true.
true.
Yeah. Okay. This anesthesia are many in perioperative care. Sometimes when you see questions, you think they are anesthesia questions, but rather it is from perioperative management. As we mentioned at the beginning, perioperative care could be pre-operative, intraoperative, or post-operative care. And anesthetized patients vomit and develop dyspnea, wheezing, cyanosis, and tachycardia. The most likely clinical diagnosis: A, bronchopneumonia; B, collapsed lung; B, C, asthma; D, exudative pneumonitis; E, acute heart failure. What is the answer?
Exudative pneumonitis.
Why do you say so?
Because it is characterized by cyanosis, bronchospasm, dyspnea, and tachycardia.
And it's usually following aspiration of what? Vomiting. All right. Management will include what? How will you manage that patient? Head up position and pharyngeal suction. B, intubation and suction of trachea and bronchi and irrigation with small amount of saline. Administration of oxygen and halothane. Administration of adrenaline, steroid, antibiotics. Administration of digoxin. How do you treat them?
Head down and lateral position.
When the thing has entered the lungs, you have to irrigate that lungs. So you have to bring them out. He vomited and the vomitus is inside his lungs. So you have
You need to clear it first through suction or manually.
So this is the correct answer. Intubation, suction of the trachea and bronchi, and irrigation with smaller. Not that you just go and be pouring one normal saline inside the lungs. It's drops. As you just drop the saline, you suction, you drop, you suction, you drop. That is how to lavage the lungs. Which of the following observations is or are mandatory after an abdominal operation, such as cholecystectomy? A, rate and volume of respiration. B, pulse and blood pressure chart. C, central venous pressure. D, 4-hourly temperature. E, intake output charts. Mandatory. The only one that is not mandatory here is this. So this is true, this is true, this is true, this is true. This is a major operation. This is not mandatory, this is false. In care of an airway in an anesthetized patient recovering from unconsciousness, lateral position is more effective than semi-prone in draining secretion from the mouth. Insertion of an airway in the mouth always ensure a patient airways, and so need not to be checked. The chin should be supported with fingers and the head extended, and the tracheal tube should not be left in situ until the patient recovers, as it is most uncomfortable. Suction should be available at all times. 22, what is our answer? Patient is recovering. I believe you've seen patient recovering from anesthesia now. What do you do? Ha! This everybody is sleeping here.
No, sir.
Okay, sir, A is correct.
A is correct. Recovering from anesthesia.
B is correct, sir.
Oh, wow.
A is false.
A is false. Oh.
B. Okay. Then C is true.
C is true, of course.
D is true.
D is true.
An endotracheal tube should not be left in situ on the patient until the patient recovers. It is most.
As it is most uncomfortable. Okay.
Very uncomfortable.
Not be left. Ha.
So D is false. False.
Why is it false?
Sir?
Why is it false?
Is the only guarantee of an airway.
Endotracheal tube should not be left in situ until the patient recovers, as it is most uncomfortable. Is it? It should be left.
Yes, sir. It's usually left in situ until the patient regains consciousness. Then it is removed.
Post-operative hypoxemia. Okay. We have only 1 minute to go. So there's question of this oxygen administration. You should know about oxygen administration, whether use of prongs or mask, oxygen toxicity, effect of oxygen toxicity, post-operative nausea and vomiting. You know about it. What drugs predispose to that? You know, some patients after operation, they'll just be vomiting. If you stop some certain drugs, they just stop. Okay. This upper airway operation, we talked about it. Patient can't breathe. Okay. This is also an upper airway obstruction. Upper abdominal operation. Sorry, I said upper. Yes. Pulmonary. Oh, it's not even pulmonary. I thought it's pulmonary embolism. Now, hemorrhage 24-hour post-operatively. That is, what is that? What type of hemorrhage is it?
Secondary.
Really? Okay. After
Or
Reactional hemorrhage.
It's reactionary.
What is primary?
Intra-op.
Is that person trying to answer our question? Primary. What is primary?
Primary
Intra-op,
hemorrhage
sir.
is hemorrhage within 24 hours of surgery.
Intra-op.
Reactionary.
Reactionary.
24 hours.
Less than 24 hours.
Yes, sir.
Then
Secondary.
greater than
Greater than
24
24 hours. 7 days.
This definition of cardiac arrest, you should all know how to define cardiac arrest. Okay. And management. Please go and read it too.
Yes, sir.
Yes. The management, all these are cardiac arrests. You see them giving adrenaline. Go. If they are treating patients in cardiac arrest, they will give them IV adrenaline. Have you ever seen that during resuscitation?
Yes, sir.
What other drug?
Atropine, hydrocortisone.
Okay. On this, look at this. You are giving us what are not in the option.
Okay. Digoxin, sir.
Which of the following drug may be used in the management of cardiac arrest?
E.
You said digoxin? You give tablets.
Adrenaline, sir.
No, you said digoxin now. Digoxin is not tablet. You open his mouth, put tablet, and wait for it to take effect. Lidocaine, hydrochloride. Have you ever seen anesthetic lidocaine? Yes, now.
Okay.
What of magnesium sulfate in cardiac arrest? Have you ever seen this one GPP?
No, sir. They use it for eclampsia, but not.
Yes. What of sodium bicarbonate? You remember I told you acidosis? You remember?
Yes, sir. So, yes, sir. You can counter.
What of adrenaline? You've seen that one?
Yes, sir.
Dr. Hashim says it's digoxin.
I've taken it back, sir.
Cardiac arrest, you see, it's just featuring. Okay, what here? Which drug?
Maybe use
isoproterenal. Yes. Calcium.
Isoproterenal. Yes, sir. For hypokalemia.
Okay. Cardiac massage. Complications of external cardiac massage. Okay. What is a complication? You can fracture the rib, is that also?
Yes, sir.
You can lacerate the liver, is it true?
Yes, sir.
Yes. Can the stomach perforate?
Yes, sir.
Are you sure? That one is
from a fractured rib.
That one is a hollow viscous that is protected by the diaphragm.
Okay.
What of the spleen?
Yes, sir.
Yes. But you know the spleen is behind. It's lying along the long axis of the 10th rib, extending from the 9th to the 11th rib. Laceration of the diaphragm, is that true? So the only common ones usually is this first two. This one
yes,
is
sir.
9th to 11th rib from behind, except you want to just go and do your massage from the lateral side. What are the parameters you monitor during cardiopulmonary resuscitation? This one is simple. You are doing resuscitation in A&E. What will you be looking at? Whether the patient is still alive or dead?
Size of pupil, carotid or radial pulse, level of consciousness, spontaneous respiratory effort, blood pressure, everything there, sir.
Yeah, everything.
Except me.
Yes,
except
sir, everything except C.
Now, of all this, which one is the most reliable?
It's urine output, but it's not
Carotid
here.
and radial pulse.
Whether patient is dead or alive, which one is most reliable?
B, carotid or radial pulse.
No.
B and E. B and E, sir.
No.
Spontaneous respiratory effort.
Spontaneous
Data of the
respiratory effort.
people, sir.
No. I hope.
Size of pupil.
Of course, when I say everything is no, you next one, take that one. Why is it? What is the most reliable sign of absence of life?
Spontaneous respiratory effort.
No. If
It's of the pupils.
somebody, if somebody goes into cardiac arrest, why do you do CPR to resuscitate him? You even give defibrillation. If that is the most reliable, you just say, okay, the heart has stopped beating. Let's just allow him to, let's go and bury him. The most reliable is loss of autonomy. You are doing CPR, all the sphincters have relaxed. You see gastric secretion is coming out from the mouth, pouring out from the nose. But because you are a super surgeon, you still want to open the heart and do massage. The patient has already lost all his autonomic reflex. The pupils are dilated and fixed. That patient is dead. When patients start losing all these sphincteric functions, he's dead. Postoperative convulsion could be due to pyrexia, okay, epilepsy, hypocalcemia, hyponatremia, water overload. We have 10 more questions to go. Postoperative convulsions.
This is the true, sir.
B is true, yes.
C is true, sir.
Calcium, true.
True.
D is true,
E,
sir.
true.
Yes, sir.
And E
E,
is
true.
true.
E is true, sir.
Yeah. Management of hyperpyrexia after anesthesia. Hyperpyrexia. What do? You go and check it.
Yes, sir.
Atelectasis, this one is common. What happens? It's a common
Urinary area obstruction.
Is a common post-operative complication, especially after thoracic or upper abdominal surgery. I've said this multiple times. The patient doesn't breathe, it will collapse. Usually occur 5 to 7 days after operation?
No, sir, it's immediately.
First day post-op.
False. So you should know how to classify post-operative complication. They are classified as what? Immediate, and late. These ones are related to anesthesia. These are
immediate.
4 hours. Okay, it's commonly caused by hypoventilation and impaired coughing. True or false?
True.
False.
Hey, so let me just do it like this. Which one is the correct one? Because you said true and false at the same time. The patient don't want to breathe because of pain. He's having hypoventilation and it's not coughing out secretion. It will accumulate, block the bronchioles, and will develop atelectasis. So let me cancel this one and put true. Can be prevented by prophylactic antibiotic therapy. Is this true?
False.
Predisposes to bronchopneumonia.
True.
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 Yeah, it's true. 43. I feel like this question is too lengthy. An X-ray of the chest may show, it's related to that question. Pulmonary embolism, yes. This is it's an assignment. Please, everybody should read about pulmonary embolism. He said A, see 90% of patients preceded by clinical evidence of thrombosis.
True.
90%.
I don't know the statistics.
In the
Most of
majority
them
of
have
patients,
evidence of thrombosis in the leg.
what is the percentage? In the majority of patients, is caused by emboli originating from the calf.
True.
That is true. Is
True,
it?
sir.
Okay. Pulmonary embolism. In most cases, occur within first 14 days after operation.
True.
Pneumonia, myocardial infarction, does not abnormal.
True.
Please, let's all go and read about. It's a very important topic. Which of the following drugs will be used in pulmonary embolism? You see that? Questions are coming.
Streptokinase.
All of these can be used.
Streptokinase.
All of them.
Morphine too can be used. Yes.
So go and
Management. Principles of management.
Pulmonary embolism.
Embolectomy.
Operative hiccups may be caused by what? Irritation of the tract. Of course, this is false. Irritation of gas. True or false?
Is it true?
True or false?
True. False.
True, sir.
Which one?
True, sir. True,
false.
True. False. Okay.
Irritation of mucosa of the esophagus or the stomach by anesthetic gas.
False.
It's true.
True, sir.
Retention of urine. Have you ever seen somebody with depression having hiccups?
False.
Distended stomach.
False.
True. Peritonitis.
True.
Peritonitis is true.
The last but not the least, everybody must get this question. Yes. Failure to pass urine 12 hours post-operatively in spite of adequate food therapy. A is usually caused by heightened athletic activity. B
false.
Is caused by pain.
True.
Yes, this is false. This is true. Is the most commonly caused by urinary urethral obstruction.
False.
It's commonly caused by urethral obstruction.
False.
What is the common cause?
Pain.
Pain, yes. Will not give rise to a palpable distended bladder.
True.
It's true. You might not see distended bladder, there are retention. It's best treated by catheterization.
True.
Best. You know, there are steps. 12 hours. 12 hours. You know, what is the first step you take?
Hot water bottle.
Not just go and start catheterization because of the risk. Yeah, all the answers. I will send it to the group so that you use it for discussion. I believe.
Thank you, sir.
I believe you don't have any question because I'm the one that was talking for the past almost.
Yes, sir.
Wow.
Thank you so much, sir.
So thank you very much. You can.
God bless.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
Sir, how do we get the questions after the class?
No, I'll send it to
group.
Okay, sir. Thank you, sir.
Thank you.